Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Heinz-Josef Klumpen, staff specialist and medical oncologist from Amsterdam University Medical Center in Amsterdam, and Dr. Chris Verslype, professor of clinical digestive oncology and head of clinic from UZ Leuven in Leuven, Belgium. They will be discussing challenges in managing advanced hepatocellular carcinoma, from selection of first-line therapy through later lines of therapy. This episode is part of a larger educational program titled Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors. For more information on the experts, along with a link to the complete program, including a downloadable slide set covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi everybody, I'm Chris Verslype. I'm a hepatologist, but mainly during the years I've transformed into a digestive oncologist, but still of course by heart I'm a hepatologist working in Leuven, the heart of Belgium, near to Brussels. And Heinz-Josef, it's up to you now to introduce yourself.
Yeah, thanks, Chris. We know each other for many years now. We do more or less the same, but I'm a medical oncologist, funnily enough, but we have lots of things overlapping. I'm a medical oncologist in Amsterdam, and I'm specialized in HCC, cholangiocarcinoma, and neuroendocrine tumors. So what, if I may start then from the historical perspective, because when we got in 2008 sorafenib, I never heard of any treatment for HCC, and medical oncology was not involved even. Chris was as the gastroenterologist involved, but medical oncology never heard of. Fortunately, I knew sorafenib from kidney cancer, but otherwise no idea. And I remember that all the gastroenterologists, they were not impressed by sorafenib at all, because nobody knew anything about dosing. Nobody knew anything about the right indication. It was just done. And now we look back and we see that at least 25% of all patients had Child-Pugh B being treated. And now we had to look back and say, like, Child-Pugh B, they don't do anything on sorafenib. And we have given hundreds of thousands of patients, I suppose, this drug for nothing, which cost a lot. And we have not invested this money in good research. We gave it to everybody. And 10 years later, we learned our lessons, let's say, and now we're in a situation very comparable with 10 years or 14 years ago, where we have all these options and we just do what we do. And just to have a perspective, what happened after introduction of sorafenib, that we, had no limitation to indication and that everybody just did whatever they thought would be useful. And we waited much too long to draw interesting conclusions and to learn our lessons. And maybe this podcast might help to change that behavior and to see what can we do to earlier learn the lessons, let's say. Mm-hmm. One of my PhD students had a look in collaboration with other international centers at a couple of thousand patients, and they found that you can calculate what the response to treatment is. The PROSESH score. It's a calculator online, Chris. Did you know about that?
No.
Oh, that's good that I mentioned it then. It's if you just put in PROSESH2, PROSASH, then there is the online calculator. And that is just telling you if you put in certain parameters, like albumin, some just normal parameters of a patient, then they will tell you what the individual overall survival of the patient would be if the patient would get sorafenib. And I think that's what we need. That's a whole discussion we have today about first, second, and third line treatment. We need calculators like that to be able to counsel our patients and ourselves what is the best for this patient.
Yes. Even if we have some poor overall survival, the better is how many months of life is a patient willing, in fact, to sacrifice for a certain reduction in the possibility of side effects. And so this is about patient preferences. This is about important, and we know from studies that have evaluated patient preferences in HCCs. It was a German study that looked into that, that really asked patients with advanced HCC what they wanted, and it seemed that they had a preference for longer survival. So there is no doubt that patients with HCC want to live longer, and we know that this has been a major emphasis of the trials. So survival benefit is important, but they don't want to suffer, and even a 10% reduction, for example, in diarrhea, if this is possible, they want to sacrifice 1 month of life prolongation. So there is indeed what you say, side effects and survival are important, but patients have some preferences about that.
And that's the nice thing about this calculator, I think, because it predicts you if the patient will have benefit at all, and might even be dying earlier. And obviously for disease like this, it's very important to realize that the way we talk is sometimes more important than which drug we choose for such a disease.
Yes. Yeah. Can we, perhaps it's now the time to discuss some new options and what is now the standard, in fact, in first line, taking into account this heterogeneous patient population that we have with HCC. We are now 2022, so it's there is an impressive evolution in possibilities. But when you review the evidence, Heinz-Josef, what is your idea now in the Netherlands? What is the first line? Do you have some typical patient that you would have no doubt, or are there still any doubts that you have to treat everybody with immune checkpoint inhibitors or combinations?
Yeah, good start. So of course, the atezolizumab, bevacizumab is the first-line treatment. We have now more than 1.5 year experience, and we have next to that sorafenib and lenvatinib. For most patients we choose for checkpoint inhibition, we try to only treat Child-Pugh patients. But the questions which I have is, what do we do with the screening of esophageal varices? So do we do in gastroscopy for each patient? That's one with cirrhosis. And the other question is, what do we do with patients with NASH or NAFLD? There was abstract in ASCO GI recently, and also had a few patients. With those patients, there's so much more toxicity and very limited data on or at least very limited survival. And I still don't exactly understand what's going on here, why this is happening.
I also have to say that, again, the German physicians looked into a real-world experience with atezo-bev, where they could clearly show that patients who have Child-Pugh, they have a median overall survival of about 6.8 months, and so far below the results of the IMbrave study. So patients are treated with Child-Pugh, and so the fact that you in Holland tries to limit your patient to Child-Pugh, this is not practice throughout Europe. So we see also an extension of the criteria and a lesser survival. So this is really the case. So this is true. So if you don't stick to the inclusion criteria of the IMbrave study, you will have poorer overall survival. For the NASH population, of course, you can look both ways. So it is suggested that there is the benefit in comparison with sorafenib seems to be less. So it seems that NASH patients also do well under sorafenib. So you don't have to give them atezo-bev, but of course it does not say that immunotherapy is not effective in this population. So this is a bit of the complex reasoning behind it. On the other hand, if you look to the new combination from the Himalaya study, so the STRIDE regimen with durvalumab and tremelimumab, you see that the subgroup of NASH patients, in fact, performs very well. So it seems that you cannot just say that immunotherapy is doing less well for NASH. It's specifically about the combination that is tested in the trial. So still, it's very much population dependent. Be careful about subgroup, sub-analysis, but still, it points to the fact that we have to stratify our patients in clinical trials according to etiology. And this is this is really getting into the picture, in my view. We know about this variceal problem, so patients need to be endoscoped. What do clinicians do? They start off with the immunotherapy compound. They wait for introducing the bevacizumab compound for many weeks later, after eradication of the varices and so on. So there may be some concern, some less proper use of the combination because of real clinical issues in the clinical practice, and this may hamper the results. This is something that we do not to lose time, waiting 6-7 weeks before you can embark on a therapy in a patient with an advanced HCC. At that stage, still stage A, you can have the appearance of some or extension of a portal vein thrombosis. But if you very carefully look into the data of the IMbrave, you also see some bleeding events in the control group. You don't see these bleeding events, for example, in a purely immunological immune checkpoint study like the Himalaya. There, the bleeding events are minimal in this group, but when you give a TKI, you should also pay attention for bleeding events. But even with this selection, they still had significant bleeding events, and with some grade 5, that means that the patient died. So the warning is there and should be very carefully listened to in clinical practice and adhered to. And it's my strong feeling that every patient who is presenting with an advanced HCC, where you see the collaterals anyway on good imaging, but you have to do again an endoscopy and assess the risk of bleeding. I think this is good clinical practice.
True, that happens here as well, but we do wait with the treatment.
The fear of waiting in the mind of a physician, it may be appropriate, but in the communication with the patient, losing an opportunity and facing the issue that the patient will be too weak or having biochemical abnormalities that preclude starting the treatment after a few weeks, it's not very acceptable. So, but of course, you should calculate this risk in the decision that you make up front and discuss this with the patient and so on. So,
if you have a patient who you think is not suitable for Atezo-Bev, what's your other first line choice, Chris?
Then it would be a TKI, of course. Having said that we still give systemic chemotherapy also in young patients, for example, who have a non-cirrhotic background, where you may induce a response with classical chemotherapy. This is completely based on phase 2 studies. So there is still, for some patients, young patients, not on the background of cirrhosis, for us, a window sometimes of GEMOX and so on. That's something that we often have to say. This is a limited number of patients, but the young patients with advanced HCC on a background of a non-cirrhotic liver, we may still consider that. Having said that, our main choice would be sorafenib, and we choose more sorafenib because we have more established second line options than third line options than following sorafenib. So that's a bit my choice, a bit respecting the evidence that we have. Although lenvatinib may be an excellent also alternative, that's true. But I'm looking further down the line of what we would give in the future.
So moving to second line treatment. So you have a patient on Atezo-Bev. What is your next choice of second line treatment?
As an academic, of course, I have to say we try to include the patient in a clinical trial. And I think this is something that's not always so easy because you need to be in a perfect shape as a patient. It all depends on how you started. And so you need to be Child-Pugh. And we have this protocol of continuing the atezo component and adding to that either sorafenib or lenvatinib. So this is an interesting study that's going on. That's our main preference. So that's something.
How many of those patients who are, let's say, fit and well in the first line, what's the percentage when they progress who you think are fit enough for second line?
20%. In my world, but I have to say that this is, of course, there are other factors that play a role, but your patient should have been during a certain time stable under the therapy. If a patient is progressing at the first evaluation following the Atezo-Bev, he is not a candidate for this trial. So you already select patients that have a benefit on the therapy, that are stabilized or having a response for some time and then progress. that can really enter the trial. So there are some selection criteria that play a role, and therefore for this approach, it's in my opinion about 20-25%, which is not a lot. It's different, of course, if you go immediately at first progression for a second line option, and then I would for sure go for a TKI. Yeah? And then my choice would still be to respect the evidence that has been gathered during the last years, and that we start with sorafenib or lenvatinib, but in my case sorafenib, and then later on, if the patient is tolerating well, for regorafenib. This is the big discussion that has been going on in guideline committees, whether we should put all options in second line following atezo-bev at the same level, or that we should respect some information that we gathered from the first line approaches.
So the second line, we have the exact same choices here in the Netherlands than you have in Belgium. So that's a good that we have parallel worlds in that way. And I totally agree to put patients in clinical trials where possible. But what my experience is so far is that we had the chance to give a second and third line treatment in various variations. So sorafenib and then regorafenib, where I was each time surprised the patients who do well on anything. Those patients did good on sorafenib and on regorafenib for a long time. And I also had the opportunity for a few patients, because of the compassionate use program, to have atezo-bev in third line, and for about 6 patients, I think. And of those 6, about 4 after 1.5 years now that we're treating them very well, have responded, have good tolerance. And so that's another reason why I think that, because of all the options we have, as very comparable to the situation of melanoma or kidney cancer, that a registration of systemic treatment is the way to go. Otherwise, we will learn just bits from prospective studies. But I guess there is a huge opportunity to collect data of patients who get systemic treatment, especially because it's a very expensive treatment. And
yes. And Heinz-Josef, how would you approach that issue? How would you organize this registry of these data?
Because I worked before with the Belgium Cancer Registry, and I would like to launch a project where we, on several country nationwide basis, we collect the data of systemic treatment for HCC. Because I think when we would wait for randomized trials to get to know the right sequence for the right patients, then we will be more than 10 years later. First, we have a national cancer registry. Some countries have that. And within that cancer registry, we have the chance that we not only register all detrimental parts of the disease, which are crucial to determine the BCLC stage and the Child-Pugh stage, but also what are the treatments, not only first line, second and third line, even toxicity, progression-free survival, overall survival. All these data are standard as part of the registry, which is unique, I understand, in internationally. But that is something we have, and therefore that's what we want to do in the Netherlands anyway. But we are a small country. It's just 17 million people here. With a very low, we have about 800 new cases per year. So we will never have enough data to really go without international collaboration. But I understand that many other countries have national cancer registries, like France and Belgium and many Scandinavian countries. And I think with a combined effort and starting to collaborate already now, because I guess within the next 2 to 3 years, we will have enough patients to get enough data to draw some conclusions about subgroups. And I think the other thing, what we do here in the Netherlands, because we have a few centers, and in those centers, the medical oncologists are all super specialized, which means there's not a whole group of medical oncologists within each center who can discuss cases together. So what we do is, as medical oncologists, in between those institutions, we talk to each other. So once every 2 weeks, we get together and discuss about 5 patients where we have doubts about the indication or some questions. And I think all new indications should be discussed either regionally or in a small country like the Netherlands on a national basis. It's just very interesting to have many options and to have limited experience and to discuss all the variations, which you just discussed yourself, Chris. Because isn't it, what do you do in your team? Do you have colleagues to discuss with?
I really think so. Every patient, of course, is at all institutional level. The systemic therapy for HCC, our group is the only one who is treating the patients on HCC in our hospital. So this has been decided up front. And all patients are discussed before starting treatment in the group. Having said that, sharing the experience with other centers, as you tell me, is interesting. Of course, there are contacts with other centers. We do MDTs with other centers in the network of hospitals. But I don't think I'm grasping fully all the indications in my contacts. We are more investing in Belgium in platforms to discuss side effects of therapies, because immunotherapy may be very complicated. What to do with a patient, of course, that received immunotherapy, has a huge problem. How would you tackle that? You stop the therapy. What do you introduce? So the side effect management, there are excellent platforms and discussions, but we are not yet so far that we have a platform of discussing this throughout different centers in an organized way.
And I think what you mentioned about the immunotherapy side effects is interesting, because I have my colleagues from melanoma and kidney cancer sitting next to me, so I can quickly discuss that. But what they have not had experience with is those patients who have already liver diseases like cirrhosis, or these patients with, immunotherapy and cholangiocarcinoma. So they have no experience with those two combinations, which is quite unique with HCC.
We even encountered a case at a discussion where they started a transplant patient on immunotherapy with an absolute catastrophe on the liver, with an acute rejection only 5 weeks later. So the risk is it ought to be in the 40%. For acute reaction, but I have the impression that it's really it's really impossible to start a patient on immunotherapy when you have a liver graft, for example. So this is something that came out of this discussion, but
interesting.
So some colleagues started it.
I have a different experience, because I have somebody on with liver transplant on atezo-bev in third line for 1.5 years now.
Because of one single case. We closed this discussion in our centers, that we said we cannot try that, while you have an excellent experience. So the question is, can we predict in some way who will
That's one thing.
fail
and also,
or not? And,
if I may interrupt, sorry, Chris, but also because this patient had no other choice, because he was in third line. There was no third line in the Netherlands available for such a patient. He could not participate in any clinical trial. So for him, when we discussed it, because they're, shared decision making, it was like, well, if I'm not undergoing this treatment, there's nothing, and I will die anyway. So what do I have to lose? And we discussed it with his transplant gastroenterologist and hepatologist, and they all said, if there's no other alternative, then let's try this, which was successful, but it could have gone the same way as your patient. So I understand.
But that's very interesting, because you may anticipate a long survival with a successful atezo-bev in this setting, but you anticipate also a very short survival if you have a graft rejection. And still, you appear to be very optimistic, and you started. So that gives me some hope that you sometimes see the glass also half full in Holland. So this is quite the reverse as I would have expected. And you also base your opinion on a single experience now. So it's quite remarkable. We are not yet there where we want to be, that we are at the crossroad, that we are starting to learn, that we have to be careful of interpreting subgroup analysis from these trials, that everything needs to be tested in a proper way. But at least that there seems to be an unbelievable rationale that you can give 2 TKIs in sequence with a good outcome, but I never would have expected before that there are a lot of uncertainties now there is absolutely no evidence regarding what to do following certain first-line options, but still it's done in clinical practice. And the question is, how will we accumulate evidence now in this difficult field? And this for me, and the increasing complexity in second line, it's only an impression I have, because in the reality, the availability of all these compounds is in many countries not guaranteed. So there have been a lot of studies, but this has not yet translated into availability. So there is a mismatch between clinical study availability and what's happening in practice. So we're doing things that there is no evidence. And on the other hand, where's the evidence that we cannot apply? So this is a bit of the difficult environment where a clinician has to give advice and counseling to his patients.
Thank you very much, Dr. Klumpen and Dr. Verslype. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.